My SRship under Dr. Kranti Bhavna ma'am, so it feels a bit more wonderful to be back here and to make my presentation. So my topic is differential diagnosis of vertigo, central versus peripheral etiologies. So a lot of it has already been covered by the previous speakers. In fact, Dr. Gunjan's presentation, it encompassed almost a good chunk of what I have to say. It was a very good introduction. It was a very detailed introduction. So most of it would be a repetition or a bit of tangential approach to what Dr. Gunjan has already mentioned. There was a presentation on peripheral vertigo by Kranti ma'am, Meniere's disease, presentation on central vertigo by the previous speaker. So this classification of central and peripheral vertigo has also been explained by the previous speakers. I will try to delve into a bit more. So when we talk about vertigo, it somehow reminds me of this. This is the great banyan tree. It is the largest tree in the world. And this was a stone throws away from the place from where I did my post-graduation at Kolkata. This is at Alipur Zoo, Kolkata. Now it is spread over a few acres and it's a couple of 100 years old. Now this banyan trees, it has given these vertical shoots down to the ground. And now the time has come when each of these shoots have developed into an individual tree. So much so that it's very difficult to ascertain which was the main trunk and which is the trunk which is propagating now. So when I think of vertigo, every time I think of vertigo, somehow I am reminded of this tree. That it is so vast that if we go to cover each and every aspect of it, it will not take minutes, it will not take hours, it might take days, probably even weeks. In fact, every single differential diagnosis of vertigo can be a topic of presentation, a topic of an entire conference on its own. So what I will do is I would restrict myself to very few and pertinent things which are related to my topic, and then we'll proceed further. So my first encounter with vertigo was before I joined MBBS, and this was when I watched this famous movie by Alfred Hitchcock, Vertigo. And when I watched it for the first time, it sent shivers down my spines. Now it's not a movie anymore, but even after seeing so many patients, vertigo still sends a shiver down my spine a few times a week. So how does this happen? Now vertigo, as it has been mentioned so many times before, it's a challenge both for the physician as well as the patient. So a patient comes with vertigo. Obviously, there is still a lacunae in the information to the general public about how to approach vertigo. So when a patient comes with vertigo, he first goes to Dr. Gunjan. After that, he treats most of the cases. If something left untreated, then it comes to me. Then probably some vertigo cervical, something was saying, it goes to orthopedics. Ma'am is there, physiotherapist. A lot of physiotherapists are involved in this. Medicine, eye, everybody is involved. And we all tend to have our chunk of the pie. We have our own approaches, and that is why when ma'am said that a time has come when dedicated units to treatment of vertigo is the need of the hour. When a very concentrated approach to treatment of vertigo to give relief to the patient, that time has now come. And a lot of work is being done recently, and it's a very important topic. And lots of youngsters, even my postgraduate students, they are taking up vertigo as a very specialized field of study and practice. So if I have to summarize I'll start with the summary of my presentation only. And it can be done in just 3 questions. First of all, does the subject really has a balance disorder? Dr. Gunjan has given all the differential diagnosis. What are the things that can be a balance disorder, what are not balance disorder? I'll again go through that. If there is a balance disorder, is it central or peripheral? Central means related to the ear system, vestibular system. Peripheral goes to the central nervous system. And last, what is the probable etiology? So if these 3 basic questions are answered, it almost 90% of our work is done. So it's that simple. I mean, it sounds a bit like all those Instagram videos which we see where they, within 2 or 3 minutes, they cook an entire chicken dish. And every time I go into the kitchen trying to make those chicken dishes, it almost comes to body blows with my wife. So It sounds a bit simple, but I think it needs a much better understanding to answer these three very basic questions. So, first question, does the subject really has a balance disorder? Dr. Gunjan has mentioned about dizziness, blackouts, visual disorientation. What is important here is that we have to classify according to the systems that are presenting. If it's a cardiovascular system, it may go into the feature of blackouts. If there is history of atherosclerosis, it may go into the system of blackout. Lightheadedness, there was a very good discussion on postural orthostatic hypotension. A patient with Parkinsonism, Parkinson's disease can have orthostatic hypotension and may complain with vertigo. Again, there are medications, toxins, some toxins which are not allowed in our state, and all those things can also cause vertigo or vertigo-like features. There is psychogenic. Dr. Gunjan again showed pictures of a patient who come into the criteria of psychogenic vertigo, and sometimes very simple things like anemia, a person who is losing blood for a very long time or a very low hemoglobin level can also present features that may mimic vertigo. So the first is, does the subject really has a balance disorder? So next we come to the second question. We have decided that the patient has a balance disorder, and we have to decide whether it's a central or a peripheral disorder. And how do we decide that? It's a simple diagram of our vestibular system starting from the ear, middle, inner ear and to the central nervous system. We draw a line somewhere in between. Again, it looks like such a simple classification that anything on the left hand side of this line is a peripheral vestibular disorder. Anything on the right hand side of this line is a central vestibular disorder. This line is probably more porous than the India-China border, and a lot of pathologies are there which go from one part to the other part and vice versa. So this demarcation cannot be absolute, but it is just a reference frame on how to approach when we first starting this. So why this division is so difficult? What makes this breakup difficult? Breakups are always difficult, but this breakups is a bit difficult because number one, vague symptoms. चक्कर आ रहा है, सर घूम रहा है, हिल रहे हैं, दुनिया डोल रहा है. It's very difficult to elicit a typical vertigo-like history from a patient. Second is the obscurity of the pathophysiological changes. Lots of these changes are still not known to us. Third is inputs from several different systems of the body. There is the muscular system, there is the CNS, there is the air and autonomic nervous system, there is the eye, there is the ear. So sometimes the symptoms, they jump from one category, or rather they present from all these categories together. And it's very difficult to keep a mind on all the different systems that are involved by just by looking the history or the examination of the patient. Then there is low sensitivity and specificity of the clinical tests and investigation. In the recent years, there has been a significant improvement in this. Now we have very sophisticated investigations also. But the problem comes because there is not one simple investigation that can study all the different aspects and all the different systems and all the different pathophysiological changes of vertigo. So there is a VEMP which will treat or which will diagnose a different component. There is a VNG which will do something different. Sometimes working in a resource limited setting or a private setting which is not entirely dedicated to vertigo, this unavailability of resources, the latest resources, can be another thing which makes the diagnosis of this vertigo difficult. Then comes the central compensatory mechanism. If it is a peripheral vertigo, we all know that after some time the body compensates on its own, and then it becomes the diagnosing the entity even more difficult. And last, symptom complex as an outcome of pathological as well as physiological process. It might not necessarily be a pathological process only that is resulting in vertigo. Sometimes an overstimulation of normal physiological process can also result in vertigo or vertigo-like features. So how to proceed? Now there are, when my teachers, they started teaching me how to approach cases of vertigo, they told me there are three important things, three primary things which should be done when you are approaching a case of vertigo. First is history taking, the second is history taking, and the third is history taking. So history taking is probably the most important part of approaching a patient of vertigo. There is in life as in vertigo, there is a saying that with 20% of the effort, you can do 80% of the things. For the remaining 20% of the things, you have to put 80% of the effort. So for almost 80% of the patients of vertigo, just by a proper detailed history taking is more than sufficient to come to a conclusion. Now this thing is repeated by almost every speaker, and in spite of that, it doesn't lose its value, because in vertigo, in balance disorder, history taking is probably the most important part of your examination and diagnosis. Then comes clinical examination. Dr. Gunjan has already gone about it. There is a neurological investigations. We have lots of investigations that were coming up, as I mentioned before, and there are radiological imaging which can be done. So these things I am keeping out of the purview of my presentation right now, and will focus more towards how to differentiate between central and peripheral vertigo. Another thing, how to differentiate between vertigo and instability. Now, you can go on giving the definition of how to define vertigo, how to define instability. Vertigo means rotating, spinning, ghumna, chakarana. Instability means ladkharana, swaying, tilting to one side. And all these definitions are good as long as we are presenting or we are writing in the examination. To diagnose the patient clinically, the most important thing is you should have seen a lots of patients under your senior, or you keep on seeing them, so that after a time you come to realize just by seeing the patient for the first time or talking to the patient for the first time whether it is vertigo or instability. It's an acquired reflex. You have to practice only then you can come with a certainty that this is vertigo and this is not instability. And I think again the most important part of how to differentiate between this is to listen carefully. Many of the times, if you just listen to the patient, suppose a 40-50 years old female patient comes to you and she starts with चक्कर आता है, हाँ आता है, सुबह में आता है, हाँ आता है, दिन में आता है, हाँ आता है, कब आता है, खाना खाते तो आता है, और कब आता है, काम करते तो आता है. That 50-year-old female patient will have features of vertigo almost 24 hours a day, with almost every associated features will be there. So if you listen carefully, only then you will be able to diagnose or able to come to a conclusion whether the patient is having a vertigo or an instability, and then you can proceed further. Now this is a chart, very integral to my presentation, but I have nothing new to add to it. This is the chart which we have been studying since first year. Unfortunately, we have to remember it. All the postgraduate students, you have to remember it. What are the features of vertigo? On history taking, the presentation, onset, progression. I think each of one of know this chart, so I won't go on reading everything. But all these important factors: the presentation, how it presents, what is the onset, what is the progression, the precipitating factors. In peripheral vertigo, there are different set of precipitating factors, a change of head movements. In central, it is usually absent. Associated features, in peripheral, there will be associated ear symptoms, there will be tinnitus, vertigo, as we learned about Meniere's disease. In central vertigo, it will be about more of central features, and so on and so forth. So this is a very well-known differentiation between the central and peripheral vertigo, and each one of us, they should have this classification at the back of our mind. Again, what makes it difficult? Because sometimes, not sometimes, almost every time, it's the exceptions which prove the rule. And I'm just taking, there are lots of examples like this, but just a few examples. Ototoxicity. Now, ototoxicity is supposed to be a peripheral disorder because it works on the outer ear cells. But what happens? Ototoxicity, you take any ototoxic drugs, anti-cancer drugs, tubercular drug, it affects both the vestibular system. Every time both the vestibular systems are affected, there is a decreased input from both vestibular systems together. So features of a unilateral or peripheral vestibular lesion, it doesn't appear in ototoxicity, and the patient may present with imbalance also as compared to the vertigo. Cerebrovascular strokes, a central lesion, but many a time a cerebrovascular accident, they present with acute vertigo. Lots of central lesions, such as a multiple sclerosis or infarction, they present with only vertigo as a patient, true vertigo as a patient. So even in central vertigo lesion, such as multiple sclerosis and a few more, there can be a true vertigo as a true presentation. Now, when we do a Valsalva, when we cough or when we sneeze, and the patient gets a vertigo, then the first thing that comes to mind, probably there is a perilymphatic communication, peripheral vertigo. But it also happens in a condition of Arnold-Chiari syndrome, where a Valsalva or sneezing precipitates vertigo. So the point is, that chart is not definite. That chart is just to help you come to shorten the list of diagnoses that you have. After that, you have to use your own wisdom and your own knowledge to pinpoint the disease with further accuracy. So that is the history part. Now coming to the clinical examination.